Welcome to today's webinar, Strategic Pathway for Infection Prevention and Biofilm Defense. My name is Subject Van Kempensaket, and I'm the Medical Education Manager at Smith+Nephew. I'm joined today by our speaker, Kevin Wu, and Smith+Nephew's Clinical Resource Specialist, Kim Flannery. Kim will support in addressing product-related questions in the Q&A. Two housekeeping items before we get started. We invite you to submit questions by typing them into the question panel found by clicking on the Q&A icon along the bottom menu. You may submit your questions at any time. We will collect and address them during the Q&A portion at the end. Secondly, for your certificate of attendance, please complete the survey at the end of the presentation. Indicate if you would like a certificate and provide your name and email address, and a certificate will be emailed to you by the end of the week. I'm pleased to introduce our guest speaker, Kevin Wu, who is no stranger to this group. Dr. Kevin Wu is a full professor at Queen's University, Faculty of Health Sciences in Kingston, Ontario. He is an adjunct research professor at Western University. He is an affiliate scientist at the Institute for Education Research, University Health Network. He is an established Canadian researcher and educator in the fields of wound management and chronic disease management. He has published over 180 peer-reviewed papers and has received national and international awards for his work. He is a founding member and the past president of the Canadian Pressure Injury Advisory Panel. He maintains an active role in clinical role in wound care.
The title of the presentation today that I will be talking about, Strategic Pathway for Infection Management and Biofilm Defense. And this is my disclosure. The purpose of the presentation today is really hopefully by the end of this program, we'll be able to have a discussion about biofilm-based wound care and infection management pathway. And hopefully the information will be able to help you to differentiate local from deep spreading infection. And we'll be using some cases to examine the step-up, step-down approach to address underlying wound etiology and bacterial burden. And finally, we're going to praise some of the evidence for the use of topical antimicrobials to treat biofilm and deep wound infection. And they're very, very different as well, based on the management pathway. So just a reminder that chronic wounds continue to be very common across the globe. Based on a recent systematic review of all the publications across the globe, the prevalence is estimated to be affecting about 2.21 per thousand individuals globally. So I think that really constitutes a sizable number of population suffering and living with chronic wounds at any given time. In fact, about 40+ million new wounds would develop every year. So you can imagine this is really a growing concern, in part due to number of chronic diseases, comorbidities that we see, like diabetes, and also obesity problem. People become more sedentary. So chronic wound is a common problem. In fact, almost 1/3 of all these wounds are very difficult to heal and may last for about a year. And you can imagine the burden, the toll they put on the patient and the system is extremely high, extremely significant to people who are affected by chronic wounds. And one of the conversations we must have today is about chronic wound management when biofilm is involved. It is estimated about 80% of all chronic wounds have biofilm problem. And depicted in this picture here is the phases that involved in wound healing. Usually with acute wounds, with normal wounds, we expect those lesions to follow a very expected trajectory of wound healing from hemostatic phase, inflammatory phase to granulation or proliferative phase, and then closure with new epithelium, new epithelialization, and then remodeling. With chronic wounds, it's quite unique in a way that this excessive inflammation involved in the pathophysiology. The most common reason for this sustained, excessive, prolonged inflammation is because of microbial colonization, with a lot of bacteria growing in the wound environment. triggering this inflammatory response. Inflammation cells, they are not really selective, that kills bacteria. At the same time, it can also destroy a lot of healthy granulation and growth factors in the wound as well. So by definition, chronic wounds are defined most commonly by the chronicity. And if the wounds are not about 34% reduction in size within 30 days, they're usually considered to be in the chronic wound stage. Because of the complexity of chronic wounds and there's a lot of different factors that involve in making decision about how to treat chronic wounds. We'll come back to a pathway that will help you to make some of those decisions. But before that, I just want to emphasize the importance of this step down, step up clinical method or approach. What's illustrated in this diagram is the emphasis on the multi-interventions that need to put in place at the very beginning when you're approaching a chronic wound, including, in this case, sharp debridement, biofilm disruption, the use of antiseptics or systemic antibiotics where appropriate, and also looking at all the other therapies that are so important as part of the strategies to address the underlying etiology. For example, offloading for individuals with diabetic foot ulcers or people with pressure injuries. Nutrition management, diabetes management, very, very important. And also I would add compression therapy for people with chronic edema or venous disease. And then gradually, as the wound continues to improve, we can probably de-escalate and reduce our intensity of effort to address the wound. And sometimes we might even reduce the number of dressing change frequencies, using a different type of dressing over time. And then at some stage, we might want to step up again when the healing is stalled, or despite all the optimal wound management that you have put in place, the wound is not really progressing the way that you like to see. Then we might have to look at some other adjunct therapy. In this case, some examples illustrate on this slide is you may consider negative pressure wound therapy, skin grafts, substitutes, or cordon dressing. So coming back to the topic about infection management, there's been a lot of debate, a lot of confusion about how to recognize infection, how to treat infection appropriately, and what is local infection versus a deep infection in wound environment. So there's a panel, a small international panel, a group of us get together and we looked at all the scientific evidence, clinical guidelines, international consensus papers, and expert experience to come up with and distill a lot of those information. You can see the variety of different clinical guidelines out there from a variety of international associations. And it's great to be able to draw on some of those prior knowledge and collective wisdom, and we distill all those information into a one-pager, this infection management pathway. So first, in order to address wound infection, we need to think about holistic wound management, holistic patient assessment or wound assessment. So we come up with A, B, C, D, and E. So A, we need to assess patient, the health, comorbidities, medications, quality of life, and the wound. B, bring in a multidisciplinary team and include the caregivers and patients to promote holistic patient assessment and management. C, the two alphabets to remember, or 2 points, control and treat the underlying etiology or causes, and also identify some of those barriers that can affect wound healing process. From there, you can actually identify what the goal is for wound healing. If you can control and treat the underlying problems, the expectation is those wounds should progress to healing over time, versus wounds when you cannot really control and treat the underlying problems. For example, wounds with malignant cells with malignancy, unless you treat the underlying etiology, then your outcome, your goals will be very, very different. And that's why, from there, from C, then that would lead to D, deciding on the appropriate treatment and goals in partnership with your patients. And then between D and E, you have the time. So once you're able to identify the goals, part of the treatment should involve the 4 basic principles. We call it the time principles: tissue debridement, infection and inflammation management, M for moisture balance, and then E for the edge of the wound. So we don't want to go too much into details about the local wound care today, but I think when we address wound infection and biofilm problem, we touch on some of the key elements around why are we doing tissue debridement and what are the ways of debriding a wound? What are the local treatment that we can use to treat infection? And then select the right dressing for moisture management. So, and then we come back to look at evaluation and reassessment of the wound from time to time. So to give you a case scenario, just to illustrate why it is so important to address the underlying problem. This is a 70-year-old female with diabetes, obesity, with kidney disease on hemodialysis. And we initially discovered a wound on the calf area where there may be pressure causing this type of injury. So we just initially we decided, well, perhaps this is really a pressure problem, and we follow the local wound management, looking at debridement. Upon removing the top layer of those necrotic tissue, we identify, and in fact, there is a crevice, there's a big space, undermining area, and we're able to drain copious amount of drainage, and it's quite malodorous. You can actually literally see the volume of wound fluid, very thick, very cloudy material coming out from the wound. I think we drained almost about 500 cc of this type of fluid. And as the wound continues to progress, we actually start to identify there are some unusual bony fragments on the wound tissue. This is not exactly down to the normal bone, but this is calcified material that is built up on the wound bed. So now we have to think about this may not be just a pressure injury anymore, but perhaps there's other underlying problem. Upon doing a biopsy, and it confirms the diagnosis of calciphylaxis, which is a progressive occlusion of dermal blood vessels due to diabetes, due to the calcium deposit and buildup. And now you got this calcified material on the wound bed. And you can imagine the treatment, in order to correct the underlying problem, it's not just about offloading and pressure redistribution and optimizing the nutritional status. But at the same time, we need to treat the calcium, the high calcium level, by correcting the hemodialysis, by looking at different medications to address the thyroid hormone, to increase the solubility of calcium deposits using sodium thiosulfate. So, and eventually we're able to achieve better outcome to create better wound and promote better wound healing. So hopefully you're convinced that we do need to address the underlying problem before we do anything else. So the other major concern about why chronic wounds are progressing to healing is because the presence of bacterial burden and increased burden is a key concept behind infection problem. And this is a very important guideline, published by the International Wound Infection Institute. It's been refurbished and republished in 2022, so it's quite new with a lot of recent up-to-date literature and evidence. So according to this guideline, infection is defined as an invasion of the body with microorganisms that have the potential to cause destruction and evoke a host response. And by recognizing some of those signs and symptoms, we're able to differentiate whether the wound is actually contaminated, colonized, versus now there's more obvious damage on the tissue, then we can actually define local infection. And as the bacteria continue to move into deeper compartment, there are other physiological changes and signs we can recognize as spread infection or systemic infection. And definitely, biofilm is placed in the center of this whole discussion. When you're dealing with wound infection, always think about the presence of biofilm and how to manage biofilm. And by recognizing the reason why we want to recognize and differentiate local from spreading infection is because your treatment modalities, your selection of strategies will be very, very different. As you can see on the slide, topical antimicrobial for local infection versus systemic antimicrobials for spreading and systemic infection. So for people not familiar with biofilm, this is a nice little video just to showcase that in wound environment, there are always bacteria floating around. They're ubiquitous. And they start when there's a growth in number of bacteria, they able to communicate with each other. We call it crumb sensing, and they gather more bacteria in the same place, producing the extracellular substance or polysaccharides, proteins, and other elements, building this sort of a really nice defense mechanism that protect the bacteria from the invasion of antibodies, antibiotics. And that's why it's so difficult to eliminate biofilm. And they're very stubborn and recalcitrant to treatment because of the presence of biofilm. So it's a survival strategy for bacteria. So based on the importance and now there's so much literature out there that actually help us to understand the implication of biofilm and wound healing process. There's been a lot of effort put into defining the biofilm-based wound management approach. And I'll walk you through this approach a little bit in the next few slides, but just want to highlight the three major points here. We need to think about vigorous, good cleansing of the wound. We need to think about the use, ongoing use, and sequential use of antimicrobials and topical antiseptic agents. And of course, at the same time, we want to combine all the other key strategies to address the underlying problem. And hopefully, after 2 week challenge of using your antiseptic and antimicrobial dressings, we're able to see wounds improving over time. And if the wound is not improving the way that you want to see or has deteriorated, then you have to go back to this. There should be an arrow to go back to the beginning, to the drawing board to look at the underlying problem as we actually address all the other problems in the wound environment. And this slide, I just want to impress on you the science behind biofilm and the different types of interventions that may be available to us in the next 5 to 10 years in order to fight biofilm and prevent the formation of biofilm by bacteria. For example, using light therapy, hyperbaric oxygen, we might have some idea already that because we have those technologies available to us. But some of the emerging technologies, for example, using bacteriophage therapy, that those type of phages can actually lock onto the bacteria and destroy the bacteria so they would not be able to produce biofilm, or modulating the pH in the wound environment, making it more hostile for bacteria to grow, using surfactants as cleanser or some type of dressing to help remove biofilm more easily. So I think this is such an interesting space in the near future. But first of all, I just want to come back to address how we can assess and identify biofilm. That is one of the most sort of a contentious area of wound management. So when you look at ABC, those wounds, they look unhealthy, right? I think we can all recognize that they don't look like a healthy granulation tissue, healthy wound bed that we like to see that is on a healing trajectory. In fact, you can see that there's a little bit of this yellowish gelatinous material built up on the wound. In B, the granulation tissue look kind of friable and very red, more vibrant than usual. And then C, definitely there's a layer of fluffy yellowish fibrinous material covering the wound bed. So then, based on your assessment, do you think this is considered as no infection, or should we consider this as a covert biofilm-related infection, or overt classic infection, or spreading systemic infection? So those are the four choices we encounter wounds that you are dealing with. So this is not always straightforward and easy, because by looking at pictures, we're missing a number of things, including smell, including the amount of X-ray. We have to look at the dressing that we used before. Was it drenched with wound fluid, to identify if there's an increase and change in the characteristics of wound fluid produced by the wound. So based on the literature review and all the other documents that we have looked into, we put all the common signs and symptoms described in the literature into this algorithm, into this pathway, and helping you to differentiate biofilm or covert infection from overt spreading systemic type infection. So just a reminder, biofilm, usually they grow on the superficial layer, the upper compartment. versus overt infection, classic infection. Now the bacteria they have invaded into the deeper tissue. And that's why I come up with this upper and lower acronym to help people to remember some of the common signs and symptoms in relation to local versus spreading infection. So U for unhealthy tissue, friable tissue, dusky color, discoloration, yellowish material, gelatinous stuff, potentially. That may be an indication of bacterial growth and biofilm formation on the wound bed, causing the tissue to be very friable, for example. The capillaries are weak because of all the energies are being utilized by the bacteria rather than maintaining the infrastructure in the wound environment. There may be increased pain because of all the inflammatory cells, the MMPs produced or triggered by the presence of bacteria. So those MMPs can actually stimulate the nerve ending, causing pain. Poor wound healing. Again, the energy is being utilized by the bacterial growth versus for tissue growth that is normal in wound healing. Increased amount of exudate, part of the inflammatory response, and also smell, especially when there is anaerobic bacterial growth. Usually we can smell the wound from about from a few, 10 to 20 feet from the wound. Versus for lower, when the bacteria have invaded into deeper compartment, the wound can get bigger. When you have bony tissue, when you have deeper structure exposed in combination with all the other signs and symptoms, for example, increased in warmth, increased in edema locally, there's redness in the peri-wound skin, then it may help us to validate and arrive at the conclusion that there is a deeper spreading infection that we need to address with the use of antibiotic or systemic agents. So just to show you a few pictures, I'm sure we can all come up with some ideas and conjure up some images that are associated with local biofilm related problems. For example, on this slide here, with increased amount of exudate, there's a lot of wound fluid on old dressing, or soaked with this sort of bluish greenish colored drainage, maybe suggests to us the presence of Pseudomonas aeruginosa. And in this picture here, you can see all this hydrofiber soaked with wound fluid. Unhealthy granulation tissue. In fact, there's been some people talking about granulitis, inflammation of granulation tissue, as a term to describe the inflammatory response that had changed the characteristics of granulation tissue, making them more friable, very easy to bleed. Or sometimes you can see the tissue structure, the tensile strength is so weak that it can just sort of slide off the wound bed, creating pocketing bridges on the wound bed. And of course, at the same time, with increased amount of exudate, dried up exudate, and also with the dead cells that are left behind on the wound bed, creating this gelatinous material, yellowish material that also considered to be part of this unhealthy granulation picture, granulitis picture. So keep in mind, clinical assessment is less than perfect. There are individuals because of circulation problem, because the immune system it's been compromised by the use of medication or other type of immunosuppressive drugs, then they may not be able to mount those inflammatory signs we just talked about in the last couple of slides. So yes, we do need to do more comprehensive assessment, recognizing that there are factors that can influence the production of inflammation locally. Then it brings up to the point about, should we be swabbing wounds? Yes, in some situations, yes, we will. Especially if your clinical assessment, the initial assessment, suggests to you that there is potential bacterial damage and the bacterial growth, the burden that is causing damage to the wound, then the purpose of doing a swab, a culture, is to identify the specific pathogen such that antibiotic treatment can be, or the appropriate treatment can be used and selected. So we don't, in other words, we don't just swab all wounds indiscriminately. We want to make sure that you use your judgment to be more informed about when to swab a wound, recognizing that all wounds are colonized by bacteria. So invariably, when you culture a wound, there's always growth. In order to obtain a good culture, a lot of scientists and clinicians promote the idea of using a Levine technique. So first of all, cleanse the wound with saline. Debride if you need to clean up the necrotic tissue and healthy tissue, cleanse again. And then you select a small area, about 1 centimeter square area, which is considered to be the cleanest. You apply your culture tip, the swab, and rotate. At the same time, apply the pressure to extract the wound fluid, and then insert into transport medium and send to the lab. And that's what we call the Levine technique, that would be able to produce a report and an analysis that is most informative of the type of bacteria that is causing the infection in the wound environment. So after you have recognized that there is a infection problem, so hopefully some of the signs and symptoms and the pathway would be able to help you to look into wounds more carefully, recognizing some of those subtle signs. The next step is to think about vigorous cleansing. It is important step because by cleaning the wound, you're actually able to remove a lot of the residual bacteria. Certain techniques are very important to generate enough pressure and also the right approach to disrupt the biofilm structure, recognizing that even antimicrobial agents would not be able to penetrate into the biofilm structure to destroy it. So the most effective way of disturbing a biofilm is doing something more mechanical. And now we actually have some interesting chemical agent potentially that can actually help us with this endeavor as well. But in general, when you're cleansing a wound, think about using the right type of fluid and right amount of fluid, and also the right technique. So the right amount of fluid, by definition, in general, use about 50 to 100 cc of irrigants per centimeter of wound length. So just dribbling a few drops of saline or tap water or sterile water on the wound is not really cleansing per se. You're just moistening the wound bed without without disturbing the wound bed or without disturbing the biofilm structure. At the same time, you want to make sure that either using swiping, scrubbing, or irrigation technique, you want to generate enough pressure to remove the biofilm structure. So in this case, I'm using a monofilament pad. I was kind of very enthusiastic and very vigorous cleansing. And this patient actually has neuropathy, so she wasn't experiencing any pain. That allows me to be a little more aggressive with the cleaning in order to remove some of the fluffy tissue on the wound bed using this monofilament pad as well. There's also some new agent with surfactant material. It's a very interesting chemical agent with the hydrophobic and hydrophilic end. And the theory is when the hydrophobic tail insert into the biofilm structure, the hydrophobic elements, they repel from each other and facilitating the breakdown of biofilm structure. So literally, the material can be lifted away from the base of the biofilm and from the wound bed, and then allow irrigation, allow the wound swabbing to be more effective. So yes, whatever irrigation solution that you're using, also think about the pH. We recognize that bacteria don't like to grow into a very alkaline, a acidic environment rather. So that's why you want to make sure that solutions are slightly more acidic to maintain this acid mantle on the wound and on the skin, and avoid any alkaline solution put into the wound. So sharp debridement that you may be familiar with, a lot of times you don't even have to use a pair of scissors or blade. Sometimes even just blunt instrument. By using enough pressure, you're able to remove some of the unhealthy material on the wound bed. And I think the point I'm trying to make is it may look like it's part of the wound, but those material, the unhealthy looking material that is not pink and light red in color, they should not be there. They're basically proteinaceous material that can harbor the biofilm, the bacteria, and facilitate their growth. So I think that's why the point is we need to be more vigorous in our cleansing methodology. And in the second video, and we're using forceps just to scrape off some of the more stubborn proteinaceous material. And in some cases, if the material is thicker, then we have to use a sharper instrument using curette. And then in some cases, we might actually be more aggressive to cut down to the bleeding surface. So this is what we call active debridement versus passive debridement, conservative debridement that doesn't really cut into the bleeding space or bleeding tissue. In addition to sharp surgical, there's also autolytic debridement, creating an environment for the endogenous cells to produce the enzymes that we need to digest all the necrotic tissue, mechanical, using pads, using irrigation, enzymatic agent, biological using megatherapy, and there's also new terminology in the most recent consensus document talking about using oxidative agents to facilitate oxidative debridement. So along the line of enzymatic debridement, I often think that this is a really underutilized technology. It's a very effective way of debriding wounds, even in between sharp debridement, recognizing a lot of patients we see may not be able to come back to clinic every day to benefit from a regular and frequent sharp debridement or mechanical debridement. So enzymatic agent can actually play a very important role. First of all, it has the enzyme harvest from the bacteria to destroy denatured protein. And just a reminder, the major protein in the wound tissue is collagen. That this sort of three strands that locked in together this tri-helical structure. So once it denatured, they would change the architecture and change orientation of this protein, and allow the enzyme to recognize the target for interaction. So in this little video, you can see that there's presence of necrotic tissue and slough that need to be removed. So the application of centrocollagenase with the thin layer on the wound bed, the collagenase would diffuse to the base of the wound, looking for denatured protein because of the changing in the shape compared to healthy collagen. And they go to the root of the denatured protein, and almost like a pair of scissors, chemically, they cleave off the denatured protein at the base, allowing all the slough and necrotic tissue to be removed. And there's some papers talking about the effectiveness of collagenase in the management of biofilm. So it's not just attacking the denatured protein, but also at the same time able to remove and disturb the biofilm chemically. So you can see in this case study, an individual with the wound, you can recognize there's quite a bit of yellowish material, sloughy tissue that is unhealthy. We don't want to see yellow material on the wound. So I apply the collagenase. After day 12, you can see the increased amount of granulation tissue on the wound bed. And we continue with this modality for about a month. You can see that by 26 days, the wound is almost closed, or at least about 92% surface reduction. And just a reminder, after you have disturbed the wound bed, we presumably remove a lot of the biofilm bacteria, reduce the bioburden. Bacteria, there's always persisters, there's always residual cells left behind. And it doesn't take long for those bacteria to grow back to where they were before and reform the biofilm. That's why after each mechanical sharp debridement, after the challenge, we need to think about ways to keep the bacteria under control by using antimicrobial agents. So there are a variety of agents available to us: silver, iodine, PHMB, chlorhexidine, Dakin solution, honey, and some of the fatty acids dressing as well. And some are more preferred, especially with silver and iodine that I'll be focusing on in the rest of my presentation today, versus Dakin solution. It's highly toxic and it's very, very corrosive, very, very alkaline that can damage a lot of the healthy tissue and not always effective in eliminating bacteria. So if you look into this pathway, we initially talk about the holistic patient assessment, walk you through the different signs and symptoms to differentiate local versus deep infection. And from there, depends on whether you're dealing with a biofilm-related infection versus a deep infection. There are first-line treatment that we recommend for the different types of wound infection. In this case, this is an individual with a very deep wound, a lot of wound fluid coming out, malodorous, and there's quite a bit of erythema around the wound, local edema. So it's consistent with spread infection and overt infection. As you can see on the slide here, the first line treatment we recommended based on literature review is silver type dressing, able to manage and able to deliver the key ingredient to interact with the bioburden to reduce the spreading infection problem. And you can see that we have selected actical flax material on this trochanteric area. It's very flexible, very easy to pack into the wound without damaging the granulating wound base. This is a nice little video to illustrate the science behind the crystalline silver. They're like clusters of silver molecules locking together. Upon interaction with wound fluid or any aqueous environment, they will release ionized silver into the surrounding tissue, into the surrounding environment. And that differentiates the ionic silver from metallic silver. So once silver has reached down to the bacterial level, they can get to the cells, interrupting the cell wall function. So all the toxic material start to build up within the cells, and eventually they burst and die. So that's how what's the mechanism behind silver on bacterial. So I think the key message is looking at the right wound, recognizing there's deep infection, select the right product. We identify silver perhaps is better than any other agents for the management of deep infection, and we're able to achieve some really significant improvement for this type of wound in conjunction with all the other strategies that we've put in place, not just silver alone. At the same time, we have used antibiotics. At the same time, we use a air mattress in order to offload the area to relieve the pressure. So what about covert biofilm-related problem? Those are the common signs and symptoms in relation to biofilm-related infection. And the first line treatment we recommend based on your evaluation to address biofilm problem is iodine-based product, cadexomer iodine. And you can see this wound, basically, there's a lot of unhealthy looking granulation tissue, also increased smell, increased exudate, but there are all the other sort of classic signs, inflammation and edema and peri-wound skin erythema. So with the presence of biofilm, the cadexomer iodine has been confirmed and validated in this systematic review that the cadexomer iodine is more effective than, in this case, hydrofiber with silver against biofilm. And this is a nice study just to illustrate this slide here, the diagram, comparing with all the other silver dressing, cadexomer iodine, CI, they're able to reduce the bacteria, the biofilm, to almost nothing at all. We also look at another systematic review and meta-analyses to determine if cadexomer iodine is more effective in promoting wound healing. And we come up with this conclusion that wounds treated with iodine dressing were 2 times more likely to heal than standard of care without any antimicrobials. And that's why, that it's so vital that when we think about wounds that are not healing, we need to step up to make sure that we introduce some of those agents as early as possible. So cadexomer iodine is an interesting product. It's basically a starch molecule able to release iodine similar to the release mechanism as the linocrystalline silver upon interaction with the wound fluid. The more fluid in the surrounding environment, the more iodine molecule is going to be released from the beads. It's able to absorb a lot of fluid, and that's why I like to use this type of product for a more exudative type wound in order to maintain moisture balance. And this is a nice little diagram to show you that when there's more fluid, faster release mechanism, more iodine is being delivered in the wound environment in order to fight infection more effectively. Similar to silver, once it gets to the bacteria, it interrupts the cellular function and the bacteria dies. And this is a good case to illustrate how we introduce the cadexomer iodine for this wound. Looks very unhealthy looking, lots of slough, unhealthy tissue, fibro islands of bleeding tissue, lots of pain. The wound is not healing according to what we expect to see, despite compression therapy for the swelling, because this patient actually have a history of lymphedema. And we corrected her or tried to address the diabetes. Her blood sugar was not that bad. So despite all the interventions, this wound is still stalled with all the other signs suggesting to us that we're dealing with biofilm that need to be that we need any type of intervention to address that. So because of the size of this wound, and I thought about using iodosorb powder. And you can see that there's those granules, those powdery stuff that is spread on the wound to cover a very large surface area. And over time, we're able to achieve interesting outcome with healthy tissue growing in the wound, less fluffy tissue. So the iodosorb is able, even though it's not really considered as a debrider, but because of the ability to interact with the wound environment, it has this interesting desloughing property. I love the powder because it's so versatile. You can apply on the wound and making sure there's a little moisture, allow the powder to stay on the wound bed. In some of the area that has that's very, very difficult to dress. For example, in this case, in between the toes, in the toe web spaces, there's maceration, there's potentially fungus, and I want to address some of those problems. So I can spread the powder in those interesting space. So whether you're using silver or cadexomer iodine for the treatment of covert or overt infection, we recommend follow a 2-week challenge. Use the agent for at least 2 weeks. Yes, you may see some improvement after a few days of use, but continue with that to ensure that you actually address the majority of biofilm problems. And after 2 weeks, you come back to do your evaluation again. You might want to discontinue the agent if the signs and symptoms of infection have resolved, or you want to continue with antimicrobial if you're still concerned about the risk, or if you're concerned about the wound still has some residual infection problem. Or you might want to switch to a totally different class, a different category of antimicrobials, because what you saw, the effectiveness at the beginning, and now it has gradually plateaued. And then this is a good time for us to think about other type of antimicrobials. And over time, and despite all those interventions, wound may still have difficulty progress to healing, to complete closure. So according to this step up, step down paradigm, you might want to step up introducing growth factors, introducing skin substitutes, or in a lot of cases, we may consider negative pressure wound therapy. And that's exactly what we did with this individual. We treated the biofilm, and things start to get a little bit less effective. So we want to close this wound as early as possible so we can send the patient home. We apply the negative pressure wound therapy, single-use therapy, in this case, the Pico dressing on the wound. We're able to actually reduce the wound size by almost 60%. So with this presentation, I hope that you recognize the importance of biofilm and implication of biofilm in wound management. And by following this pathway, the important part is to look at holistic assessment, recognizing signs associated with biofilm infection versus classic infection, and then utilize cadexomer iodine for biofilm-related problem versus silver for classic infection. And the outcome could be quite positive with a first standardized approach to biofilm and wound infection problems. Thank you so much for joining me, and I hope you enjoyed this presentation.
Yes, thank you very much, Kevin, for the engaging presentation on this very important topic of infection management and biofilm disruption. We'll begin our Q&A. There's lots of questions that have come in through the chat. You can still submit your questions. Just click on the Q&A icon. And if your question is not addressed today, we will commit to following up. The first question, Kevin, is what do you think are some of the barriers to adoption of the 2-week challenge logarithm, and how can we overcome that?
I think that's an excellent question. So I think hopefully with this type of tool, with this type of educational platform, it's a great opportunity to disseminate the information for people, because I think I saw the poll question earlier that some of us may not be aware of this 2-week challenge idea or the best practice recommendation. So now I think we can actually be part of this community to spread this message that when you're using a topical antimicrobial, making sure that we use the same material for at least 2 weeks, even when the wounds continue to improve after 1 week of antimicrobial use. So you want to make sure that you actually adequately and and completely eliminate all local bacteria. That's why the idea is to continue the treatment for at least 2 weeks and come back for the evaluation. If the wounds are not improving, then you might want to switch to different products or different categories of local wound treatment altogether. I think part of the challenge is the lack of knowledge. Part of the challenge is that people always have the wrong idea that if wounds have improved after a few days of use, then we can stop the topical antimicrobial. So in other words, I think we need to continue the treatment for at least 2 weeks.
Okay, great. Thank you. Another question. If you cleanse a wound with normal saline before swabbing it, won't that dilute or skew the swab results?
There's always a very wonderful question and debate about this approach. Now, this is the Levine technique, and this is the best approach. So when you're swabbing the wound, you don't want to swab the pus and send off the lab. We saw the pus. We see the pus. You know that's a pus. And also the other idea is, the important message is you don't want to send surface contaminant to the lab, because they don't always represent the pathogen, the actual pathogen that is causing the infection problem. That's why you want to clean off all the contaminants with saline first, and then you select the cleanest area and apply the pressure, rotate the culture tip, extract the wound fluid to get the right pathogen from the wound tissue. That will help you to determine if there's actually a bacterial load that we need to be concerned about, and type of bacteria.
Okay, great, thank you. Another question. If biofilm is suspected for a localized infection, should the frequency of dressing change increase?
Excellent question. Absolutely. I think you have to match the frequency of dressing change to the volume of exudate produced from the wound. Usually, if there's an infection problem, there's an inflammatory response causing increased amount of exudate, then I think that's a good indication that you need to change the dressing more frequently. As we have seen earlier, the release mechanism of either silver or iodine-based products, the more wound fluid, the faster the release mechanism. Even in most cases, the dressing has the sustained release mechanism to stay on the wound for about 72 or sometimes even longer, 72 hours. But if you have a lot of wound fluid, you might actually losing all the active ingredient within 24 hours. And that's a good indication that you need to come back and change the dressing more frequently.
Thank you. This next question, it's pertaining to Acticoat. Do we need to soak Acticoat in water first before use, or coat it with Intersite gel? Is that enough?
I think the correct answer depends. In my practice, if you're using the Acticoat or silver dressing for the management of wound infection, I would expect high volume of exudate produced from the wound environment. So usually I would say no, because there's a lot of wound fluid. You want to have a dressing able to wick away as much fluid as possible, and the wound fluid would by itself be the aqueous agent to ionize and activate the silver and release the silver from the dressing itself. Now, if you have a dry wound, arguably, would that be appropriate for, does it really suggest to you that there's a infection problem? And yes, some of the ischemic wound, you might want to consider introducing antimicrobial prophylactically, even though there's not a lot of good evidence to support that practice. But in some situations, diabetic patients, they may not be able to have the inflammatory response, or they don't have a lot of wound fluid because of circulation problem. And in those cases, I might consider moisten the Acticoat with some sterile water, with a small amount of gel to activate the silver prior to the application.
Okay, great, thank you. I'm going to do one last question, and then we're going to be at time. This is regarding chlorhexidine. Should chlorhexidine ever be used on a wound?
Chlorhexidine should not always be used on the wound. I mean, there's a lot of different solutions out there. And a lot of times people, when you use chlorhexidine, it can be a soap. We never use any soap in the wound because of the alkalinity. We don't want to, alkalize the wound environment and defeat the defense mechanism that is so natural to the body by acidifying the local wound bed. So never use any soap material. So a lot of other solutions that have chlorhexidine may have alcohol. Again, we don't want to use alcohol-based product in the wound environment. And the only solution that is available with chlorhexidine would be not pure chlorhexidine, but the PHMB, the similar to chlorhexidine molecule. It's a longer, a few sort of chlorhexidine molecules came together to create what we call PHMB, polyhexamethylene biguanide. So if you have a pure aqueous solution with chlorhexidine, potentially it's not going to cause a lot of damage, making sure that you've got the right pH level as well.
Okay, great. Thank you, Kevin, again, for this engaging presentation and sharing your clinical expertise to educate on this very important topic. We hope that you've all enjoyed today's webinar, Strategies for Infection Management and Biofilm Defense, and that you've acquired new knowledge to incorporate into your practice. Your feedback is incredibly important to us to help to continue to meet your needs and improve our education sessions. Once today's presentation closes, a survey is going to launch in your browser. Please take a couple of moments to fill in the form and share 1 to 2 takeaways that you'd like to implement in your practices. If you require a certificate of attendance, please complete the question in the survey and provide your name and email address. And I will be sure to get the certificates of attendance by the end of the week out to you. If you have any other questions, please contact us by email at subject@smith-nephew.com or contact Wounds Canada at info@woundscanada.ca. On behalf of Kevin Wu, Smith+Nephew, and Wounds Canada, thank you for joining us today. Enjoy the rest of your evening.